Ladies and gentlemen, it's great to have you join us here for this webinar. These webinars are designed to give you an insight into what is happening in the digital world, both in the NHS, in healthcare, and in social care. And today we have three speakers. And I'm delighted to start off with our first speaker, who is Dr. Jenny Lowles. Now, Jenny is an old friend of mine because she and I trained as doctors at St Andrews way back in 1966, a long time ago. And we have continued to be friends. We've met a few times, and Jenny is more active than I am. She has some dogs and she is able to walk a long distance. But unfortunately, she had a health episode during the last year. And I'm going to invite Jenny to, first of all, introduce her and her background, and then talk about the health incident she had and how she has benefited from using an app that has been developed specifically for the benefit of patients. Jenny, over to you.
Thank you, Angus. Good evening, everybody. My name is Jenny Lowles, and I, as Angus said, went to St Andrews University from my hometown of Bradford in 1966 and qualified in 1972. Through a series of different moves in terms of hospital jobs, I eventually trained in general practice and for 35 years was a GP. I have always been interested in sport and kept active throughout the time that I was working, even though I had 3 children. My children are all very sporty, so it fitted in very well with my lifestyle. Continued to be sporty after I retired, much more time for cycling and walking, etc. But in September of last year, on the 1st of September of last year, I felt extremely tired and very lethargic. And to put it into a nutshell, over 2-3 days became bedbound, couldn't eat, couldn't really drink, didn't really want anything. Eventually got to my GP, who I had never met before. I was on no medication. I'd had no illnesses apart from, as I retired 10 and 11 years ago, had both my hips replaced, I think because I played too much squash. So I ended up in Dunphy Royal Infirmary with acute renal failure. My creatinine was 1050 when I went in, and my urea was off the scale. Potassium was 6.9. So it was quite a dramatic entry into the hospital, and eventually 3 days later ended up on hemodialysis. I had a renal biopsy, I had every scan known to man, every blood test known to man, sent away toxicology, but the official diagnosis, which I will read so that I don't get it wrong, the biopsy showed severe acute tubular injury with acute interstitial nephritis, and all the immunofluorescence, electron microscopy and viral stains were all negative. But there was a history that I had given myself, my grandchild, my son-in-law and my daughter some chanterelle mushrooms 3 weeks before this happened. And of all the things, that's the only thing that we can put a very small query as to whether this caused it. But I have nothing else in my history that would suggest it. So that was how I ended up on dialysis.
So if I can just stop you there, Jenny, you went from being somebody who was totally healthy,
independent, yeah.
I know you were healthy because you walked me through Glen Eagles, and I couldn't keep up with you. And then within 3 weeks, you were almost dead.
Basically, alerted at the hospital with blue flashing lights, and a consultant and a a nurse at either limb, you know, any limb, ECG, bloods, blah, blah, blah. Just horrible. Yeah, horrible.
Right. And then you have subsequently moved on to a dialysis program.
Yes.
And they seem to be looking after you quite well. Give us a background to that.
So the NHS renal unit in Dumfries, which is Dumfriesshire, has a population of 109,000, but there are 5 renal consultants. So they have an outpatient unit in Dumfries itself with 18 beds. They have beds at Castle Douglas and Stranraer, because the distance between Stranraer and Dumfries is 2.5 hours by car. So as you can imagine, on top of your dialysis, which takes at least 5 hours, 4 hours on the machine, half an hour either end, it's a day of your life wasted in terms of travel. But so I am lucky I can go to Mountain Hall. The unit is phenomenal. The nurses rotate around, so you have a different nurse, but within a set rota that they're on. But every single person in that unit knows my name, and every other patient by their first name. Just an amazing NHS unit, which is just really gratifying to see. Yeah.
So, Jenny, you've been looked after very well. Up to that stage, before you had your renal failure or your kidney malfunction, had you any experience of any apps that were used in the NHS at that time?
No, if you can think, it's now, I retired when I was 61, so that's now 17 years ago. And at that time in general practice, no apps were used, apart from possibly, not even an app really, because our phones weren't great at that time. So patients didn't have them. So to be offered one was fantastic. And it generally changed my attitude to the disease, and the fact that you have a little bit more control. You can see where you are. There's the ability on the test results to flick to a graph portrayal of your results, which is very reassuring if you see a downward trend, which fortunately I have done. So, again, all these things I think help your confidence, and you just feel as if you're in the loop of people dealing with you, I think.
So tell me how the hospital introduced you to the app and how you took to the app at the beginning. Did you find it relatively easy to use, or did you have somebody teach you how to use it?
No, so the app I didn't know until I asked about it, but the app in the hospital is run by the renal secretaries, and Kathy is the renal secretary that I was put in touch with. And I genuinely think it was because I pestered the life out of the nurses to get my blood results, to know what they were. And one of them said to me, "Don't you have the Patients Knows Best app?" And I said, "No, I don't." And she said, "Well, I'll just organise that for you." So she sent Kathy, who was the secretary, to see me when I was having dialysis. She took my details, and by the time I'd finished 4 hours later, the app was on my phone, and all the results that I'd had during my treatment from, I think it was January when I got the app. So from September to January were downloaded. So I can see the complete trend from the 1st of September to my last tests were on the 5th of February. So, yeah.
So we have, as a special treat for you, Mohammad, who is actually the person who built up Patients Know Best and effectively, with his team, invented the app. Mohammad, welcome to our webinar. I'm delighted you're able to join us. Just tell us a little bit about how this all started, because I have a feeling that there may be an issue that you had that prompted you to develop this.
Thank you, Angus, for that warning. It's a real pleasure to speak to you, Jenny. Thank you for bringing this together, Angus. I started a bit like you, Jenny, in that I, for my own condition, needed to know what was happening with my test results. In my case, when I was diagnosed with a genetic immune deficiency, every 3 weeks I'd spend a whole day in the hospital getting infusions injected by the doctors, and getting that diagnosis and the treatment saved my life. But the big change for me was when a nurse came up to me when I was 16 and said, do you want me to teach you how to inject yourself? And I was terrified of needles, but I was also too embarrassed to tell her that. And so she taught me on the spot. And what I then learned is that she didn't just teach me how to inject myself, she taught me to be independent and understand my own health. So from that point onwards, I changed from a grumpy teenager ignoring everything that the doctors and nurses and parents were telling me to actually paying attention to the test results and so on. So that was my background, Jenny. But then I was doing some research in the States about 15 years later, and I was asked to write a book about what happens when you give patients their medical records. And I got really excited as I saw all these examples of when a patient has their test results. It's not just you and me who benefit. There are lots of diseases, lots of situations where millions of people could benefit. And I just thought, I really want as many people to have this as quickly as possible. So I spent about a year getting frustrated that no one was doing it quickly enough. And so I thought, if I want this to happen, I've literally written a book about it. I need to just start. I certainly want it for myself. And so I came back to the UK and started it in 2008 with the rest of the team.
And then we came into contact with each other around about 2013, 2014, when I, as a shoulder surgeon, putting in artificial shoulders into patients who had problems related to thalidomide, I criticised your app.
We had very modest beginnings, Angus, when we started. We kept going, but there were lots of things to improve at the beginning.
Yeah, and but it was actually wonderful for the people from the Thalidomide Trust, because they were, if you like, a lost race. They were traveling around seeing specialists all over the UK with their thalidomide-related problems, and they really didn't want to have the doctors who saw them for the first time say, oh, thank you for coming 100 miles to see me, but I don't have your notes. So you solved that problem for them. Can you just describe how you did that, Mohammed?
So from the beginning, Patients Know Best was about having a copy of all the information. And at the beginning, the information was stored manually. But once it was stored, it was there to share with anyone you wanted and for everyone to see everything. And so, and I also know this firsthand. So, when I go and see my doctor and then sort of secretary says, which ones, what's your name? I sort of point to the two folders higher and say, that's me. You then end up being the historian and the integrator. And so for thalidomide beneficiaries, that never-ending story, it's not just the repetition, it's that actually you have a very limited time with your doctor and you want to make the best use of that time. So being able to summarize, being able to expand on demand, it's really important. The other thing I learned from thalidomide is, and I learned this from speaking to people like you and the charity, is that in the early days when thalidomide babies were born, people began treating disability as how it made them feel rather than how it helped the person. So they would give prostheses that looked like a limb, but didn't function like a limb. And what the people needed was, it didn't matter how it looked, it mattered how it functioned. And so it was only later that Angus, you and other surgeons were able to do that for the patient. But that was an example of the patients knowing what they needed, even if the rest of society didn't.
So coming back to Jenny, I'd like you to take us on your journey now. You've had your renal failure established, you have the app, and you are now monitoring whether the doctors are doing the right thing for you. Tell us, tell us how you did that and how it felt.
As Mohammed said, you're actually in receipt of your own results. So Mountain Hall, where I go, is outside the main hospital. It's built in the old Dumfries Hospital. So you're out with the main patient consultant contact. The consultants visit weekly to different patients, obviously, but you actually have on your phone the whole summation of your results. So you can if there's something you want to query, like I was querying why they took me off my erythropoietin, and it was because my hemoglobin was too good. It was 12.5, and I was able to see that on my app. And also when I saw Dr. Kelly, who looks after me, he said, oh, we like to keep you, under 11 in terms of clotting during your dialysis. So, it means that you get an instant reason for changes and things like that. So it's just really good to be able to hand a phone to a nurse who says, which tablets are you on? And she can see a list of them. Or, do you remember what your last creatinine or urea or GFR was? And I say, no, I can't remember, but I can show you on my phone, And also, although I would have to say this unit is particularly good with their letters, it would be useful if your GP didn't get the letters. In actual fact, the letters are processed within 4 days from the unit. So I think, it's a very, very efficient unit.
And I can highlight a difference between your hospital in Dumfries and our hospitals. I'm currently being seen at Nottingham City Hospital, and the blood results and the results from my investigations there don't appear in my NHS app at all. If I go to the GP and have some blood tests, they appear within 24 hours. If I go to hospital, they don't appear at all. And part of this is related to historic traditions. And one of these historic traditions is that no results can be released to a patient until a consultant has signed them off. Which means that you could wait for a long time before actually seeing the results of any tests you had in hospital. And that for me is frustrating when I hear about your experience.
Yep.
But then we have to remember we are moving slowly like an oil tanker along the sea, and eventually we're going to get there. And the NHS app is better now than it was 6 months ago and a year ago. But have you experience of any other things from the hospital that have appeared in your PKB app, or is it just your renal unit stuff?
It's just the renal unit stuff. But when I was speaking to Kathy, she suggested that I could invite the radiologist to put my scan results and things like that on. So that was the next thing that was kind of... I understand the scans and things are read in Australia, so it might take them a while to put them on my screen.
Final question for Mohammed. Mohammed, you have been working quite closely with the NHS, and I know that with the NHS app, you have contributed to parts of the NHS app. Can you explain to us why there are so many different companies involved in contributing to the NHS app? Because I've looked at the NHS app and there seem to be about 4 different companies that have links with the NHS app, either making your hospital appointments or your GP appointments or what have you. It does seem a little bit untidy. Have you any experience of what's going on?
Yes, I'll just add one thing, Angus. So my colleague Frederica and I just finished writing a book called Personal Health Records for Governments. So we looked at 16 different countries, including England and Wales, at how they give medical records to patients. And they're mostly in one of 2 environments. One is where the government tries to build one thing that would be coherent, like you're saying, but that tends to make it extremely limited and extremely resource constrained in the innovations it comes up with. And then the other end is sort of the USA, where the government does nothing, and then you have the consumers jumping between lots of different apps and often signing away too much of their privacy. So what England has done is create a marketplace where different companies can offer advanced features. And so I've seen, like you're saying, when they just have improved 6 months, 12 months, it's because they're bringing in all of these suppliers. Now, I would say that there is a messy period when new things come in that weren't originally designed when you have the architecture. And also, I think part of the messiness is because the NHS app team would like to maintain an arm's length relationship. They would like to show that this is a separate company with a separate product. I get why they're doing that, but I think patients don't understand it, and I don't think they don't need to understand it. So my one bit of it, my main feedback is it's great they brought in all these innovations, but my one bit of advice is actually you can drop the names, you can drop the handovers. The taxpayer has bought the company. That's all the NHS can take care of that contracting. The consumer shouldn't be bothered with that detail.
Thank you very much. And thank you very much, Jenny, for describing your journey. Very generous of you and very much appreciated. And we're now going to move on to Emma Dunphy. And Emma is interesting because she started off life as a physiotherapist at Homerton University Hospital, but she's now become the digital clinical lead for City and Hackney, and is involved as an NIHR Advanced Clinical Academic Fellow. So she's not only into digital, but she's into research as a Senior Clinical Research Associate at University College London. Emma, over to you.
So I'm going to briefly talk about the type of health apps that we encounter working in community services. So broadly speaking, that covers everybody. So essentially, the health apps that our patients encounter across the country and in City and Hackney specifically are broadly in two categories. One are ones that support self-management, as Jen described. How do you manage your condition? And they're, although rather the latter, but it's, for example, if you have diabetes, if you have a long-term condition where there's a specific amount of information and ways that you might try to manage that, that might be all contained in a health app for you. That could be categorized as a self-management app. They provide monitoring facilities and behavior change thing. I mean, who amongst us hasn't had a behavior change app that sort of texted you and reminded you to sort of record your walking miles or whatever that might be. And then they collect things like patient-rated outcome measures, so that there's kind of the progression of your condition or the wellness that you experience is recorded. On the other hand, you have what you guys have been talking about, the patient-held records, and they're increasingly dominant in the field, and they start to actually do some of the things that PKB does, some of the things that self-management apps do. Mo will know that we have a project in City and Hackney called PKB for SMI, so patients with serious mental illness have used PKB, and it definitely gets more into the realm of self-management than the traditional kind of sharing of sort of lab records, etc., X-ray results, although we have all of that as well. We also find that our patients are using it really routinely for managing prescriptions, being able to move prescriptions from pharmacy to pharmacy without having to go in, which is fantastic. And like you described, Angus, there's more than one engine behind our local NHS app. PKB is one of the companies that runs locally for us, but there are others. And then the more tricky end for clinicians, communication and monitoring. The reason I say it's tricky is because anything that patients are entering into the apps, sometimes there's an expectation that a physician will have that information or review it, and that puts pressure on clinicians. And we're still working through how we feel about that in terms of governance and what we want to do with it. And it really depends on the service. Some services are delighted to receive communications from patients, monitoring communications, and just straightforward conversation. But other services would find that, orthopedics would find that impossible. It's really difficult. So as an example of some evolution of a self-management app, so the earlier kind of versions of self-management apps with diabetes, I'm in the eHealth unit, so plug for the eHealth unit in primary care and population health at UCL, and that we would have done some early development of a diabetes app. The team there, I wasn't involved, but it was a great piece of work. And essentially it had decision support, emotional support, peer support, behavior change, which is where there's certain functions of the app that try to trigger you to do the good health behavior. And then they recorded data, things like glucose trends, medication adherence. But in the early stages, that all had to be inputted by patients, Now we've got interactions where EPRs contribute that information to the app, and they're a bit more integrated. And also you can have patients who have kind of more automated data collection from implants. So that's become, I mean, continuous glucose monitoring implants have been sort of around for quite a while now, and where they're connected to apps, you can get a lot of really important data over time that can help people to manage their condition. And that particular app, I think that was Help Diabetes, for example, was actually proven to, at a year follow-up, be having a positive effect on HbA1c levels, and then also cost effective and also implementable. So, you know, research goes a long way to kind of see exactly how these work. They don't all need to be researched in this way, but we learn how things can be well set up if they're well researched. Jumping to the next slide, we can see what AI will now introduce into those kind of diabetes health apps. And essentially, you're looking at how you add in machine learning to that model, and you've got sort of the same amount of data, but now you're getting kind of real-time metrics from, let's say, the continuous glucose monitoring, and you're able to identify patterns that might indicate disease progression, might indicate complications, might enable you to do early detection of complications. And even when you pull all that data together, you start looking at population health level data from a number of patients, and you're deciding, you know, what are the factors around somebody worsening? I mean, some of these things we would know, but the data makes it very clear and very hard to argue with. And then if you combine that with, for an individual to have that, you get these personalized care plans that kind of come out of it that are very detailed, because they put together this sort of very, the machine learning plus the longer term input of data. So very useful tools altogether. So then rehabilitation app. As a physiotherapist, I mean, I think hardly a physiotherapist left in England who hasn't themselves tried to make an app, because the market was absolutely flooded. I had to go myself as part of my PhD. And you know what you want to do. You want to put all this really good clinical information in it. You want it to have safety mechanisms built in. And I was working with orthopedics to do mine, and it was really inclusive video content. Does it fit everybody? Can it be sort of, is there communication mechanisms for all the information? In other words, we want it in video, audio, cartoon, we want infographics. We basically want all the different types of learners to be able to interact with the information. And then you look for those behavior change functions that engages people to what you're doing. But now we've moved on from those individual apps to kind of more, without naming companies, the more behemoth ones, where you can essentially rehabilitate any condition, and they're integrated with the NHS pathways. And that is so valuable, because now you've got people who are being monitored while they wait. If they're registering red flags in their continual updates that they provide, that's notified into the pathway, and they can be seen more quickly. Equally, if they recover while they're waiting, well, they immediately disappear from the wait list. They don't need the service anymore, you know. But that kind of continual monitoring while they're waiting is invaluable as part of kind of pathway change and transformation. So we are constantly worried about digital and red flags, and this kind of integration enables us to address that. So the reason, I guess, as organizations, we really are keen to get on top of what these health apps can offer from this sort of huge companies like PKB, who are national. We want to look at, can this change our operating costs? Does it improve care for our patients? As Jenny detailed, it invariably does. What are the increasing access? How can we increase access for patients? In other words, you know, what are the other products? Might be doctor, might be changing appointments, might be being enabled to do things like that. And then patient enablement and supported self-management. People want the power to have as much knowledge and control of their condition as possible. And that's something that the apps, I think, really offer. The more integrated they are, the more they can really offer that. And then finally, what is the big upswing? It's not quite finally, but the big upswing. Basically, since the pandemic, people are much more able to navigate digital tools. Not all people, of course, and we always have to be mindful of that. But there is basically new advances in technology, and they enable us to respond to that pressure to improve care. There's venture capital out there. People are interested in sort of innovating in the health space, and that's a really good thing. And we can always keep an eye on what the sort of huge global companies are offering us, what the big Oracle Healths are offering us in that space as well. So there's a lot happening that makes it, I think we've kind of hit a tipping point with it. And then this is the final one, I think. Yeah, exactly. So the things for us to keep in mind when you're looking at an app as a patient: is it a high quality and well-maintained product? Is it safe? Has it been through NHS clinical safety? Did somebody recommend this to you, or did you just come up with it yourself? And that's really important. And even within trust, you get people kind of recommending apps. And we know, anybody who's in the business knows, that a lot of the apps that are out there are not safe. We're not developed with clinicians, have entirely different motivations. And that's quite a scary thing for patients to interact with. But can they be interoperable and data connected? does it solve a problem that we're trying to solve clinically? Does it align with our pathway? And then the big questions around how PKB, the NHS app, and Dr. Doctor are changing this app landscape, because so much more is offered by these companies. And now clinicians like me don't have to go around developing apps. A lot of the information that we want to get to our patients is now something we can get to them through things like PKB, products like the NHS app, because we can set up interfaces there that enable our patients to interact with the same things that we would have once tried to put together on shoddy apps, you know. So that's about it from me. With the patient held records, we also have to be really careful about how we communicate it. I would just say patient held record, PKB, the NHS app, the patient engagement portal. You know, there's about 15 different ways that we speak about it, and that is driving both our patients and our staff workforce entirely bonkers. So we have got to get better at that. But otherwise, it's a fascinating space, and it's really, really good for clinical care.
That's great, Emma. Thank you very much. We'll come back to you for questions later on. I'm going to move on now to Tom Smith. And Tom is our patient representative. We are an organization which very much recognizes that we have to have patient input. And Tom has very kindly come on to our executive committee as our patient representative. And he is now going to possibly comment positively and negatively about apps. Over to you, Tom.
Good evening, everyone. My name is Thomas Smith. As was mentioned, I am an independent patient engagement consultant. I've been working in this way for around 7 years now. I work with regulators, medcom companies, life sciences companies, and I wouldn't change a single thing. It's brought meaning to my life. I live with a rare disease myself, and I would not have found this space at all without that fact. So I feel incredibly lucky in many ways. I was just thinking, I think I want to pick up a comment made by Francoise in the chat about the cultural issues at play here and the sort of paternalism. And I suppose I'll just share an anecdote, which was, about 18 months ago, I was asked to give a lecture on patient engagement to a French pharmaceutical company, which I did, which was scary and exciting, and I had a great time. But when I was preparing what I wanted to say, I Googled the first recorded evidence of a doctor and patient relationship. And what I found was that there was some hieroglyphics involved. It was ancient Egypt, and there was like, a pharaoh engaging with his shaman or something like that. So I thought, we have to be kind to ourselves here, because we've been doing this kind of doctor-patient thing for, 2000-ish years now. And that is, it's not turning on its head, but we are reaching parity. And I think that is largely because of the increasing understanding and awareness of what the patient community can actually bring and offer to systemic and commercial development and things like that. And then on top of all that, we have all this digital health, which is relatively new. And I think before I get into what I want to say, one of the comments that you made, Emma, was, about the challenges of adoption and things like that. And when I was preparing for this call, I was using the Leeds Patient Hub, which is where my care team is based, and which it's just a terrible user experience. There's no doubt about it, which is very, very, very different from the actual NHS app. But the problem is, these different platforms are branded in the exact same way. So there is no real difference when you're not interested, you don't care about, managing your health, which is probably not the majority of people, but most people aren't in this space, let's face it. We are a minority here. And if you have, for example, the Leeds Patient Hub, which again has the NHS badge on, and the NHS app, which is, it's clean, there's contrast, it's intuitive, but most people are not going to make this distinction. They'll think that was a an NHS tech-related intervention that I used, and it was terrible. So I think that's something we have to sort of watch out for. So when we talk about and think about what patients want out of an app experience, we have to prioritize simplicity and clarity. And that is going to be a combination of things like usability, accessibility, and patient-centric design. Patient-centric design in itself is a little bit of a loaded term, because we just mean people-centric, don't we? It's one and the same thing. Accessibility needs notwithstanding. I think one of the areas that I work in is health literacy and plain language. And, you know, I've said it so many times, none of this is rocket science. But I don't want to see, for example, any Latin medical terms anywhere near my app experience, you know, because I don't speak Latin and most people don't. So I think we just have to find a way to sort of develop and use a test, the tonal, like how tonally appropriate the language that we use in either an app experience or sort of plain language summaries of clinical trial abstracts and things like that. We've mentioned the clean and intuitive design. Design is probably, I think, one of the most overlooked parts of a user experience when it comes to this kind of thing. You know, you could have all the functionality under the sun, but if it doesn't grab your attention the second you open it, you're onto a losing battle, really, because design is what people notice before they even realize kind of what they're looking at. So we need to sort of grab them as quickly as we can. I mentioned contrast for people with vision loss and things like that. I think it also apps have to integrate with accessibility software and settings on all devices. Anything that you are going to use to look at an app with needs to work with it in that way. Just like little things like tutorials and step-by-step guidance, like when you get an update on your iPhone, it says, we've got this new thing here, this is how it works, this is what you can do with it. I think I don't want to struggle to read anything on an app. I think we need to have like just, you know, things like font design, font style choices and things like that, and sizing are so important. Voice commands, translation options with translations that are user tested, for example, because anybody could go to Google and translate into, for example, Portuguese, but then you could give that app or that text to a Portuguese person, and it might be, for example, Brazilian Portuguese or just nonsensical. But it's not just as simple as clicking a button. We need to test this stuff with the patient community. I think, you know, there's, so again, it comes back to design, but like just this minimizing of cognitive load. And we do that by designing, obviously, apps and experiences that are intuitive to how people use other apps in their private life, kind of thing. And I think that just like, for example, going back to the sort of Latin-based medical terminology and stuff, just things like in free text fields, we could use like autocomplete or suggestions for any sort of free text boxes. I think personalizations when it comes to notifications, suggestions for any what different piece of data that have already been shared could mean in, you know, conjunction with each other. We could have like symptom trackers, activity goals, things like that. You know, like something as well, which another anecdote time again. I was in France last week working on some clinical outcomes assessment stuff, and I sort of I said to the team I was working with, like, can we share notifications with other devices? For example, my wife, for example, like if she was receiving a notification that I need to do something on an app as well as me, it makes me way less likely to forget to do that. And it's been mentioned before, I believe, by Emma, but just this idea about data and security, like there is no trust. There is no trust in science, in corporate power, in data, ownership, and things like that, you know, and people are just skeptical about this stuff. And I think we have to labour transparency. Are people going to open an app and go straight for, well, what are you going to do with my data, by the way, if I share this with you? The answer is absolutely not no, but that's not the point. We need to make this stuff available for people if they want to know about it. And, you know, just this idea about being able to change any sort of permissions that our patient or our person gives these apps. And I think we can also think about communications functionality. My care team in Leeds, I have to call them if I need anything. And there are I think between 400 and 500 patients with my condition at the care team in Leeds, there is one phone line which is used for everything. So the amount of times you call and you just get like an engaged kind of dial tone kind of thing, you can't get through to the people that you need. I just don't want to have to do that, you know. I'd like to send a message or an email, for goodness sake, and get a response. I'm sure there are good reasons why it doesn't function like that, but nevertheless, we need to navigate around those kind of things. And I think, yeah, going back to this sort of paternalistic approach to, you know, administering healthcare, but also how we engage with the patient community when we develop systems and things like that. I don't want to hear about, we are developing an app. We're halfway through, come and tell us what you think. Because that's consultation versus co-creation, which is, we are trying to do this. How would you like to help us with it? What do you want out of it, kind of thing? And, you know, the patient community there's just so much capacity to contribute value to this kind of thing. It doesn't need to be, we can't, or we should make less determinations about what a patient community can and cannot understand. We just have to do a better job of making everything clear, and then creating the space for the patient community to actually contribute to solutions. Long story short, I think one of the beauties of what I do, it is a belief system for sure, but also when we talk about or think about what patients want from an app, we don't need to decide that for them. We can simply ask them, and the patient community are going to match any sort of commitment, enthusiasm tenfold, and they're going to tell you exactly what they want and need out of an experience. And this is, I understand why we don't necessarily approach everything like this so far, but I think that is going to change. And I thought, just in preparation for this call about a bad experience, I would log into how, for example, my psychology appointments are managed. So I get, and I'm going to talk you through it because this is a perfect example of something that I do not want to have to do. I get emailed a link to, which will take me to Leeds Patient Hub. I need to log in with my email or my phone number and my date of birth. Then I get emailed a security code. I've had to write this down. Then I get emailed a security code. Then I need to add the security code to the web page. And once I get in there, it's just the most drab, unengaging, uninspiring experience. For example, all my clinical letters are in PDFs. I just don't. That's not what I want out of it, you know. And there's, for example, there's questionnaires that I can participate in, but there's no mention of any sort of incentive or why it matters that I do this kind of thing. And again, when we talk about contributing value, data and things like that, we have to motivate people to do it. We have to either explain why you should do this or why you could do this if you want to, and explain how it might benefit you in the future to do that. But also, crucially, who else benefits from this as well? Because we can't deny that there are commercial entities or variables at play here. And I think that, like I say, I have to engage with these kind of platforms because my disease is complex, you know, it needs management. But if, for example, I have hypertension, which is, I suppose, a relatively run-of-the-mill condition to live with and deal with, I can sort of ignore all that. And I think that if we want to inspire people to engage and manage their own health more, we have to create experiences which are just better for them. And like I said, the NHS branding is it's an issue because, sorry, it's not the branding, it's the fact that some good experiences happen underneath the same brand and some bad experiences happen under the same brand. And we have to accept that we're not working with people who are interested in necessarily caring about that. Really, they're not going to interrogate, why was that? I used the NHS app, that was great. And then this is also an NHS app, but this is terrible. People aren't going to interrogate it in that way. So we just have to meet them where they are and provide user experiences that are good, engaging, satisfying, and leave a bit of a mark. We want to establish a habit here as well. So the good news is there's lots to go at.
Tom, thank you very much indeed. Fantastic presentation with some pearls of wisdom, which have been very, very well received, because you pointed out things that are really important. We're now going to open the floor. There is something called putting your hand up. If you put your hand up and ask any questions, I will let you into the discussion. So I'm just going to open it up to the whole of the audience now. And I'd be very keen to see some of your faces if you're able to switch on your camera. Does depend on exactly what you're doing. Please don't do it if it's inappropriate. But what a lovely presentation from Tom, and it just highlighted what the patients do think. Alex, as a GP who has been involved in these problems before and knows about communication with patients, what do you think we can do better?
Hi, good evening, everyone. I think all the speakers have have presented brilliantly this evening with a whole range of sort of perspectives. I think that making the apps really user-friendly and simple is the absolute key. You know, I'm a newbie to some apps. I only went on Instagram this week. And, you know, it's not that intuitive, to be quite frank. And I think, you know, my children are helping me. And I think it needs to be simple to make people make that leap. And so I think really getting user feedback on, you know, what works for them is absolutely key. So I think getting the patient's voice is key here to make them successful.
Lovely. And Francois, you were commenting during the presentation from Tom and highlighting the points that he was raising, which you felt were very appropriate. Are you in a position to be able to respond? Francois is an anaesthetist, and it's just possible he may have a patient asleep beside him.
Hi, Angus, thank you. No, I've not got a patient to sleep, but I'm not in a place where I can put my video on. Tom raised some very interesting points, and I think, you know, I do find that working in the secondary care sector myself all the time, as you did before you retired as well, you come across colleagues, and I've been frequently very frustrated in trying to move digital initiatives forward by various very simple kind of mindset problems or cultural problems where people are adamantly against sharing data openly with patients because of quite often very legitimate fears that they might be causing patient harm or providing information that, if taken out of context, can be misinterpreted and lead to patients getting the wrong idea about their condition and or the treatments available, etc. In my own personal experience, however, I found the exact opposite to be true, that most patients are actually invariably able to understand it, or at least raise the question of things where they do not understand what is going on and are able to ask the question. But by taking the paternalistic approach and refusing to share the information, we're effectively removing their voice from the equation because they do not get the opportunity to actually provide an input.
I'd like to move on now to Suhail. Suhail has developed a number of apps himself. He has a company that is marketing both telemedicine and apps across the world. Suhail, the challenge of producing apps that work and do what you want them to do.
Thank you very much. It's very enlightening to join. Unfortunately, I can't put the camera on, being in public place. Tom, your presentation has so much insight. Being an app developer for healthcare, currently I've added the GDPR compliance very strictly, adding a feature where patients can actually request directly to the admin to delete the records and notify them back in 24 hours. So that has helped gain the confidence. That has improved the compliance to my recent app of AI, because now patients have control over the admin requests from a small questionnaire. And I think this is very much in strict compliance with the GDPR UK, if not Europe. So I request that everyone who's making apps, this little form to be added to the patient interface, because patients don't have login and password, mind you. It is the doctors who have login and passwords. Patient cannot log in into the system where the apps are being controlled by the doctors. So that form is essential, and that's my perhaps only comment today. But I really learned today from all the speakers today. Thank you.
Thank you very much. Jenny, who we interviewed at the beginning of this webinar, is with us. I believe she's still in her car. She promised me she would park in a lay-by, and she's on her iPad. I've got no idea whether she can actually reveal herself, but Jenny, it's lovely to have you here.
Sorry, Angus, that's my technical not so good. I am at home and everything's fine. Yeah.
Lovely. And people were fascinated to listen to your experience, Jenny. And I did have a discussion with you about the fact that once you do a session like this, it goes public and you can't reverse that publicity. You are now famous, whether you like it or not. And
infamous, maybe.
that is one of the problems when you have patients who come on to webinars. It is really important that they are alerted to the fact that you cannot guarantee their confidentiality after that video is made. And I feel quite strongly that in relation to patient information, that is also something that patients need to be warned about. You cannot absolutely guarantee the patient information is going to remain completely secret. So thank you very much, Jenny. Now, Jan de Lang is from the Netherlands. He has set up a system, Jenny, that you would be fascinated to hear about. It's Open EHR, and we suspect it might be slightly better than what happens in the UK, but just briefly, Jan, can you just explain why you've been working so hard on this?
Yes, of course. First of all, I want to thank for the great presentations. Were very, very good, very nice. When I look to the apps, and maybe that's one thing that explains why I'm also focusing on open air, is that we face a lot of how do you say, the fragmentation of hospital information systems, GP information systems, pharmacy information systems. And it's always difficult when maybe some people can comment on that, but to introduce an app and to let it work, and then of course also to use the data that come out of that app. So therefore it's very important to have an open platform with open standards where we can exchange data, and we can all use the same data and don't have to invent the wheel time to time again. So I think that's very important, and that could give more worth to all the apps and things we can do with the apps. And one other thing I would like to mention is that we have so much apps at the moment on our market and on our phones. So I think it's also very important to create a good governance and to point out what apps are really working. And I think NHS has a great job there, and that's good to get the people use it. Yes.
Jacinta is in New Zealand, and she's joined us from New Zealand. Those of you who know these things will realize that it's not late at night in New Zealand, it's very early in the morning. And Jacinta is a physiotherapist, but rather like Emma, she's into digital health, and she's into artificial intelligence. and following a similar route to the route that Emma has followed. So are you able to chat to us, Jacinta?
Yes, no, this has been really amazing. Thank you. And when I've been doing some like digital health initiatives and work, I think one of the main barriers I've come across is like staff trust and staff expectations of change in digital health. And one of the things, particularly in New Zealand, is we have, or we used to have until a couple of years ago, district health boards. And there was a huge cyber attack on somewhere called Waikato District Health Board. And it cost millions of dollars. Lots of operations were cancelled, outpatient appointments were cancelled. And I think the public and some staff members are still a bit apprehensive of using digital products because of this. So I think from my experience, change management has been quite important in trying to build the confidence. And yeah, it's definitely had some challenges. But I think, you know, I was listening and I was really really keen with what you were saying, Tom, about you know, patient experience and not having that trust in where your data is going. And I think, you know, we do see something similar here. I've had people come in, and I've had people who are so young come in, and you know, I'm teaching them how to use Zoom. And I've actually had, in the past few months, 3 people in their 90s who I go into the waiting room and they're sitting there on their mobile phones and they show me their apps, and it's absolutely fantastic. And sometimes they're showing me a couple of things as well, and it's definitely reaching the wider population.
I'm going to come back to Tom because sorry, Raj has put a question. Is there an influx of different EPR systems that is fragmented across the UK? We could spend hours talking about electronic patient records, and the answer is, Raj, yes. There are multiple EPR systems, and unfortunately, many of them don't speak to each other, which is why Jean Delang is so keen on open air, because that does allow your information to move across boundaries much more easily. So thank you for that, Raj. I'd like to come back to Thomas and talk about communication with the hospital. It has been my challenge during the last 2 days to get a bank to agree to me being a signatory. That took me 4 hours, initially with bots, then with humans, and then having to validate that I am who I say I am through all sorts of passwords and sending me messages, two-step validation and all sorts of things. But my real experience was using Churchill to get car insurance. I communicated with a bot for quite a long time that didn't seem to be as intelligent as a human, and it was very frustrating. So I think they're getting better, these bots. Bots are computers that you speak to on the web, and they are moving in a good direction, but they're not there yet. But sometimes it's awful frustrating, and you do need a lot of time. Tom?
And I suppose, like, imagine, like, car insurance is important. Being a registered, signatory is important. But compare that with an actual diagnosis or some acute health management that needs to happen. It would make you want to throw your computer out the window. I have no doubt about it. And they have to get better. If the NHS and the powers that be want to funnel us through that increasingly, which I have no doubt they do, it has to get better, because if it doesn't, frankly, it can be dangerous.
Lovely. I'm now going to close this webinar. I'd like to apologize for the fact that I mixed up a bit of Emma's future webinar with the title of this webinar. Emma has done a lot of research into apps in the past, and she is going to talk to us in a future webinar about the problems of apps. Do you want to just mention that before we finish, Emma, and then I'll wind up?
Yeah, not just apps, but implementation science for digital health. So in other words, how much of our implementation is in our control, what goes wrong, and some things that we'll have all encountered. I'm sure anyone who's ever tried to implement anything will have walked the walk on this, but it makes for interesting conversation when we look at the big failures.
Lovely. Next week, we have a webinar which is entitled Patient Safety in a Digital World. Do digital health applications make patients safer? It should be fascinating. It's being presented by one of our directors, DJ Hamblin Brown, and we've also got Chris Moran taking part as well. Chris was the National Director for Trauma, and he was around when WhatsApp was illegal, but was being used in hospitals. And we need to get out of Chris just how that was dealt with, and how we eventually landed up using WhatsApp and got permission to use WhatsApp during COVID because it was the best way of communicating. And like so many things, if an app is good, people are going to use it. If it's easy to use, they'll use it. It's our responsibility to encourage those developing apps to make them easy to use. And one of the frustrations at the moment is that apps that are produced for health are not as intuitive as they need to be and should be. And so we're here next week from DJ and from Chris Moran about their attitude towards the digital world. And I'd like to finish by thanking Jenny Lowles for being a wonderful patient and a very good friend, and Emma for her very, very clear presentation, and Tom, we welcome patient contribution to our discussions. You're always very welcome to join these. Thank you very much indeed, and I'm closing the meeting. Thank you.
Thank you, Angus. Thank you.